The second case is the case of a 72-year-old female with dysphagia and hypersalivation. The personal medical history, we know that she had an appendectomy, is known with hypothyroidism, gastric sleeve in 2008, and grade 2 obesity with a BMI of 39. The family medical history showed that mother had a pulmonary cancer at 60 years old. The blood workup hypercholesterolemia, and the upper endoscopy shows a Zenker diverticulum of 4 centimeters under the upper esophageal sphincter on the left side. And the procedure will be a poem by Georgios Mavrogenis and Mihai Ciocârlean.
Georgios, we switch to you, your life.
Hello there, hello. So here we have a small Zenker diverticulum, and we're going to do a Z poem without tunneling. And let me tell you something. So here is the diverticulum. It's shallow, it's not so deep. Here is the esophagus. I don't use any guide wire or any tube to identify the esophagus. I always place them like this. The classic Z poem technique included injection in this part, and then tunneling up to this part, and then creating 2 tunnels along the septum. But now we're going to do something different. So the first step is to inject at here, not too much. Yes, inject, please. Okay, stop. Stop. Needle in, please. Okay. So we're doing injection over the septum. Needle out. Injection here. Not too much. Okay, stop. Needle in. So I will not use any needle anymore. Now I'm going to use my knife. I will use the flash knife. And as a hood, I have the ST hood by Fuji, which is tapered. The first step of the procedure is to do an incision along the septum.
Georgios, question. In this particular diverticulum, you can see the base of the tick because it's rather shallow, but in a longer, larger diverticulum, how do you orient yourself to know where is the tick lumen versus the true esophageal lumen?
I never have problems with orientation. The only problem is when the hypopharynx is tight and you don't have enough space for movements.
Georgios, do you have the patient intubated for the Z poem?
Yes, yes, yes. It doesn't work. Yes, always. Now it works. Okay. Italians do not intubate, but I will flush water, so saline, so it's better to have him intubated. And sometimes there is food.
Can you just go over what settings you're using
incision
for your incision?
Yes, and endocut for this part of the procedure, and then forced or spray. So now I will stick my knife inside the space, and I will inject. Knife is this? I will inject.
This is knife?
So usually there are no big vessels. I have encountered only once a case of bleeding during the procedure that slowed me down. So I want to expose the muscle, and when I expose the muscle, I will try to inject along the muscle. So now I target between the muscle and the esophagus, and I will inject. This pedal is a little bit far away from me. I will try to dissect a little bit. Yes, put it near me. So you see the white tissue?
Yes, we can see
that. The white tissue is the muscle, is the septum. The blue is the submucosal space between the esophagus and the muscle. I inject here again.
No.
Here? Okay. All right, great. All right. and here is the muscle. I can cut it a little bit. All right, and here I will stick my knife between the septum and the diverticulum. Okay, and now we have a nice image. We have the septum in the middle and some mucosal caissons around it. So I cut. Now I start myotomy. I inform the anesthesiologist that the patient may encounter emphysema. This is not a complication, it's normal. I inject again here. This is the esophageal part. I inject here. This is the diverticular part. And I see nicely the muscle. I cut it with endocut.
So you're using which
contracts.
knife are you using?
Flash knife by Fuji.
Flush knife. Have you ever used the Sumitomo scissors for the diverticulotomy?
Yes, yes. Of course, you can use this too.
Do you have a preference?
But this knife has injection properties, so I like it. There is no best knife. Many knives can do the same thing. So commonly they ask how deep you are going to cut. Here we have a thick muscle. I change the current to spray now. The muscle is thick, and when the muscle becomes thin, we are at the esophagus. So I will extend deep 2 centimeters into the esophagus. Here the muscle is thinner. So we are at 50% of the procedure because we arrive at the end of the diverticulum. I will test this by pulling back my scope in a while. Now I use spray because I encountered some vessels. I inject again. And here I have left some fibers behind, so I pull back and I will cut them. Okay, here. So we have to destroy this.
Can you go over some of the complications that you encountered and how you deal with it?
Complications are fistulas and abscesses that it has been described in the literature. Small, tiny pneumothorax is what I have encountered, and my most serious complication was when I clipped at the end of the procedure the esophagus, the entrance of the esophagus, so the patient developed inhalation pneumonia, and I had to remove the clips one day after.
Pardon, iartă-mă.
What do you think about leaving it open, not clipping the incision?
Sorry, I didn't understand your question.
Sorry, what do you think about leaving the incision open and not closing it?
Oh, that's dangerous. It will end up with mediastinitis.
There's some reports saying that it's safe.
Because now I am at the mediastinum. Now I'm cutting the esophagus. I am above the heart.
Why do you extend it so far down once you've opened up the septum?
Because I don't want any recurrence. So there are reports of remaining mucosal flap. These reports are due to shallow incision of the muscle. If you cut the muscle deep, at least 2 centimeters deep, there is no recurrence. So you have the impression here that I have finished, but we have not. Here, if you look carefully, there are some muscle fibers that remain, so I have to dissect them here.
In fact, just to reply to the question concerning do we need to close, the main advantage of this technique in comparison to diverticulotomy is that you can close easily. So that's why you can go very deep and you can cut the whole septum and then you can close. This is the main advantage of a technique in comparison to diverticulotomy. Usually we did not close the diverticulotomy, but on the opposite, we cut the septum less deeply. So as we go, so for large diverticulum, it's a perfect technique for that. So we should close for sure.
This is submucosal tissue or it's muscle?
Submucosal.
Submucosal tissue.
Submucosal tissue. I try to be sure that there is no muscle left.
Here, on your left side. Here.
So at the end,
Maybe
this is the mediastinum, huh? At the deepest part.
Yes, exactly.
That's why we need to
Exactly.
close. It's obvious.
So here there is what can go wrong during this procedure. You can forget to cut muscles at the beginning because here the muscle is thick and you may forget to omit to cut them. So here I step back and I will destroy them.
Looks all right, huh?
Yes, it looks fine. I think we're almost done.
This one is the muscularis mucosae, or it's
So
part of
I follow the line of the muscle to see whether it's any remaining part.
no, I don't think so.
Maybe here there are some tiny fibers. I will inject just to be sure. This is probably just submucosal space. Don't see any fibers. So I will step back and I will see if the passage is easier. So it's easier, and you look at the left side of my image, we can see the discoloration of the esophagus. So I know that I'm deep enough into the esophagus. And usually the pouch of the diverticulum becomes even more shallow if we are complete. You see? Do you see that the pouch disappears?
Yes.
It collapses, actually. So we are maybe done. I will just check if there are any visible fibers. This is the end of my myotomy. This is esophageal muscle. I follow the muscle layer closely to see if there are any remaining fibers. There are not. Here, no. So we are done. Now we have to clip.
Question, beautiful demonstration.
Now, yes.
If you, as you're cutting the,
Yes, please.
as you're cutting the muscle, dissecting down into the esophagus, if let's say
What kind of clips do you
inadvertently
want,
you,
Georgios?
Reopenable clips.
injure the mucosa and you enter
What
into
is
the
the question,
esophageal
please?
lumen, as you're dissecting down along the
Like a big
esophageal
clip?
wall,
Yes.
if you have a
Big clip?
mucosal injury,
Rotatable big clip.
how do you address that? Because you're closing this incision.
Is there any question? Is there any question?
Can you hear me?
No, I don't think so.
So you see that I am above the septum and the upper esophageal sphincter is open. So that's the proof that this patient will not have any relapse. We don't care if in the barium study there is a shallow diverticulum. The most important part is that the upper esophageal sphincter is open.
George's question,
Okay,
can you hear
now
us?
we have to make careful movements. No, don't rotate. Okay, there, yes, open slowly. Why? Why the TXI mode was activated? We cannot turn it off?
Sorry, wait.
No problem. Okay, here we are good. Look. Focus here, please. Open, no, open a little bit, Okay, close slowly. Close, yes, place it, please. Yes, release, okay. First clip done.
Scoate-ti excited.
Next clip, please.
What clip are you using?
So this was a variation of the poem without tunneling. 3 years ago, I was in the same place with Professor Ponson, and I presented the single tunnel technique that I published in Endoscopy, and this is the tunnel-free technique that was just published in Endoscopy. And in 2 months from now, I will publish my series of 20 cases with this technique with very good results. I think from my analysis, compared to the standard Z poem, we gain about 10 to 15 minutes. So the mean duration is 25, 30 minutes for such a diverticulum. So it is, I think, a feasible solution for many endoscopists. You don't need to be expert in poem. Okay, open closely.
When can the patient eat?
Okay, please, I will tell you. Please, okay. Close slowly. Yes. Yeah, we're done. Yes, release. So what is the next step? So this patient will not drink anything today. Tomorrow morning, my protocol is to do a CT esophagram to exclude leakage at the pharynx. And if everything is smooth, if there is no leakage, he will have only liquid tomorrow, milk and water, and next day yogurt, and for 1 week soft food. And I always ask the patient to come back after 2 months, because, or 1 month, to remove the remaining clips, because some clips are embedded there and they provoke dysphagia.
So, Georgios, compared to the difficulotomy,
so the Italians do not give antibiotics. The team by Repizzi do not give antibiotics. I give augmentin. Okay. You know augmentin? Yes. Okay. Amoxicillin, yes. And for 7 days. I give intravenous dose at the hospital, and then the same medicine in powder for 1 week. Okay, close.
Just augmentin?
Yes. One more.
I'm afraid he's not hearing us. Thierry, can you comment on the difference between Z-poem and difficulotomy?
A question in Congress is what happens with the mucosal tissue that remains. It disappears. So if you do deep dissection and you destroy all vessels, and if you put many clips, it disappears.
In fact, the recurrence rate is less, but there is no randomized today. But nevertheless, as you observe, it's obvious that it's much better. It's obvious because you go very deep, and you better control what you cut. When you do a diverticulotomy, because of the mucosa, you don't see so well. In this case, you perfectly see what you are doing. But you cut very deep, and then you close. And it's easy to close because you have a lot of mucosa.
So now if you were here, you
in
could see that the
comparison with a
patient has
diverticulotomy, you burn the mucosa, so
it
it's
will
more
disappear
difficult
in
to
1
close.
hour
In
from
this
now.
case, you cut, it's easy to close.
Open closely, slowly. Open.
So it's a nice procedure. Huh? He has done perfectly.
So
Huh?
I will try to position. Yes, close. Okay, perfect. One more. Yes, one more. Yes.
Not too many clips, George. He cannot listen. You see, he has plenty of clips. So sometimes they suffer from pain. Okay, so you need to remove the clips. Yes, this is the problem. They don't complain from the procedure itself. They complain from the clip.
If the CT is positive for extravasation, do you go back in, or do you just monitor the patient longer and expect it to eventually heal?
Rotate prior to open. 45 degrees or 90 degrees. Sorry, 90. I try to rotate it too. Come on, you can do it. Okay. It has 2.8 channels. That's why and I'm a little bit angulated. Never mind. Open. Open a little bit. Oh, okay. Open. I will rotate the scope. Yes. Open, 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 open. It's open. It's not. It doesn't open anymore. Okay. Close. Don't release. Yes. No. What I did now, I checked to see whether the esophageal lumen is open, because in my complication, I grasped with a clip the opposite side of the esophagus, and I closed the esophagus. So be careful when you close it. Release, please. Okay, we are done, but since I have ODC, COD, compulsive disorder, I will place one more clip. Yeah? Yes, one more. Okay. One more clip just above here.
Can you hear us now?
20, not 20. Yes.
Question.
Place
If
a small one. Easy clip. An easy clip. Easy clip.
Georgios, question.
Yes, please.
If your CT the next day, your CT esophagram is positive, what do?
I can't hear you. Please speak louder.
You play deaf?
If the CT scan the next day
Yes.
shows the leakage, what do
yes.
you do?
If there is a leakage, I have to come back and try to clip it with close it with clips. There was a case of a paper published in, I think, Video GI. They had a leak that was not able to be closed with clips, and they closed it with X-Tack. So clips is a solution. If you're not able to use it, we have a new device, X-Tack.
But for sure, in the soon future, suturing will be better. To avoid any dysphagia or pain following set poem.
There's just no much space to use big devices.
Yes, okay, but not
so it
not
has to be something.
Yes, okay, but the small one from Olympus, for example.
Yeah, the the suture art.
Exactly.
Suture art. Exactly. Yes, but the needle, you know, is big. Huh? Wait, no. I have to step back. Okay, okay, charge it. Okay. Yes. Nice. Can you rotate it? If you can, it would be nice. I will try to. Yes, a little bit more. Okay, nice. Okay, let's approach. Yes, here. All right, here. It's okay. Yeah, no. Close for fire. Okay. Okay, I think we're done. So this is not the end. I will check that the patency of the esophagus is okay. So I can try carefully with the cap or remove the cap. So I go slowly here. Okay, I check that the esophagus is open, and now I will check to see if I have to place any more clips. I use the cap to dislocate gently the clips. It's not always easy. I think we are okay. I take a picture to prove it, and we're done. Okay, that's it.
Well done.
We aspirate the saliva.
Georgios, I have a question. Can you hear us?
Yes, please.
You say you never lose your orientation, but
Yes.
Is there any downside to placing a wire in the esophageal lumen just to provide a visual reference, so you know that you're where the esophageal lumen is versus when you're initially starting, not when you're dissecting down?
would you like to place what? A
guide wire in the esophagus, so that you have a guide
yes.
wire in the esophageal lumen, so when you initially start your incision and you're dissecting,
why not?
you know that...
why not?
Okay.
Why not? But really, I have always the same strategy. I put the diverticulum at the left side. I put the esophagus at the right side. I have a fixed position. In the middle, I have the septum. So really, I never needed to have a guidance. And if I'm not sure, I step back 1 centimeter and I check where the esophagus and the diverticulum is. But if it helps you, of course, a guide wire does not take any significant place. It's very thin. Yes, why not? Whatever helps us to be safer, we can use it.
Thank you.
Okay, so we're okay. So you understood the technique?
Stai cu mine.
The concept?
Stai cu mine.
Nu stau cu tine, Conti.
Stai, mă, cum? Ei, tu ești rău. Te-ai organizat